joining in today's grand rounds. My name is Femi Bankole. I'm a Chief of Neurosurgery and Professor of Neurosurgery at the Lagos University Teaching Hospital. And as usual, we have several stakeholders from various parts of the world joining us today. The grand rounds, we try to put them bi-monthly, and we've done that over the last 1.5, almost 2 years now. Today's topic, the title for today's grand round is Diagnostic Cerebral Angiography. Before I introduce our moderator and presenter for today, let's just do a few housekeeping rules. Please mute your microphones unless when called upon either by the moderator or the presenter. When sharing videos, let's be mindful of what's in our background. And if you do encounter technical hiccups, we usually just wait them out and we resolve them readily. At the end of the presentation, we will have opportunities to ask questions, or if you can put your questions in the chat box during the course of the presentation. And then the moderator will read your question during the Q&A session. And alternatively, if you want to ask a question directly, then you can use the hand raise button on Zoom during the Q&A session. Our moderator for today is Dr. Chizoba Ezekwe. He's an attending physician and interventional and vascular neurologist at the Neurosciences Institute in DePaul Hospital, St. Louis, Missouri, in the United States. Dr. Ezekwe received his medical degree from the Nnamdi Azikiwe University, Nigeria, and did his internship in an internal medicine residency in Illinois, in Chicago, in the US, and then had an adult neurology residency in Georgia, Augusta University. He then proceeded to the St. Louis University Hospital in Missouri, where he obtained his fellowship in vascular neurology and interventional neurology / endovascular surgical neuroradiology. He's certified with the American Board of Psychiatry and Neurology in neurology and vascular neurology. He has also published several papers in peer-reviewed journals and is a contributory author to the book Neuroprotective Therapy for Stroke and Ischemic Diseases. In his spare time, Dr. Ezekwe enjoys playing and watching football. It's called soccer in the US, but football everywhere else. Our presenter for today is Dr. Elie Dancour. Dr. Dancour received his Bachelor of Arts and Sciences from the New York University in 2006 and his MD from Tulane University in 2011. He did his neurology residency at the SUNY Downstate Medical Center and graduated in 2015. And he has also served as chief resident in his final year of residency, and he then did a 2-year neurocritical care fellowship at Columbia University Medical Center and another 2-year fellowship in neurointerventional radiology at Indiana University, the Goodman Campbell Brain and Spine Institute, graduating in 2019. Since that time, he has worked at multiple hospitals in the Hudson River Valley in New York, most recently at Rochester Medical Center, where Dr. Kafo is currently working. He served as a board member for the UCNS Interventional Neurology Examination Committee from 2020 to 2024, and he continuously works at the Creighton University Medical Center in Omaha, that's Nebraska. He will soon be joining a private practice in Los Angeles, California, and has contributed to many published articles, and will soon be participating in a study of performing middle meningeal artery embolization for the treatment of intractable migraines. Outside of the hospital, he raises his 3 children, is an avid chess player, and maintains a strong interest in the US stock market. Dr. Dancour, I think we need to talk after this. Without much more ado, I'm going to hand over to Dr. Dancour to go on with the presentation. Over to you.
Thank you so much. And it is an absolute honor to be here. When Dr. Okafo asked me to give a talk for the West African Stroke Initiative, I was honored, and especially given that the topic is something that I'm very passionate about. If at any point you guys have any questions, please just stop me and we can talk about whatever you want, and don't be afraid to take the talk into segue. I really just want it to be as informative as possible. When thinking about setting up a neurointerventional practice, I like to think about what is possible for that practice, given the size and the scope, and what are the limitations. I think that the cornerstone of any neurointerventional practice is excellent diagnostic angiography. There's no way around it. The more quality work that you do, the better that work will show in future cases. The ability that leads us right into the ability to perform mechanical thrombectomies, right? It's critical, and it's a critical aspect of any modern neurointerventional practice to offer the capability to do strokes, right? And as well as coiling of ruptured aneurysms for subarachnoid hemorrhages, elective pipeline embolizations for unruptured aneurysms, AVMs, CC fistulas. More recently, we offer MMA embolizations for the treatments of chronic subdural hematomas. We also do things that I haven't mentioned here, like intractable epistaxis, right? I mean, we like to treat those. I think that all of these starts with the ability to perform really high quality diagnostic angiography. It's the way that I was trained, and it's something that I have tried very hard to carry on in my personal practice. One of the first things that I was thinking about talking about when I was putting the slides together is something that came about that wasn't really much of a topic that was discussed when I was a fellow. It was starting to come about, right? And the discussion between do you get radial access, do you get femoral access? It seems like people are very passionate about the discussions here. And so, okay, so we all have experience probably with both of them. When I looked, I was a little bit surprised by what I found. Just very quickly, glancingly, I saw a study where patients were receiving TPA because, that's typical of, if you're going to try to find a large cohort patient population nowadays, we're going to look at strokes and mechanical thrombectomies, and patients who, I think they looked at something like 315 patients. Of those receiving TPA and then undergoing a mechanical thrombectomy, it looks like about 4% of them had a femoral access complication, and 0% of the radial access patients had complications. Okay, so obviously it seems like glancingly, radial access tends to have less complications, which we sort of know from our practice. I was a little bit surprised to find that the length of stay seemed a little bit longer in patients who had had femoral access. But when you account for the time that it took for all of those patients to get physical therapy, there was actually no real difference. All of that is to say, though, that it appears that radial access might be associated with a lower risk of pseudoaneurysm formation, maybe some faster recovery times, which we know, right? I mean, there's no reason to keep a patient laying down for 4 hours if you had radial access. It seems like patients in general prefer it, right? And greater patient satisfaction. But, and this is what I always say when I'm asked on the topic, there's a much steeper learning curve for the operator. And as a result, the length of the procedure may increase, right? And that's important. That's something that's important to keep in mind, right? Yes, it's true. Getting radial access is probably more comfortable for the patient, probably less complications, but you really have to have a little bit of experience with it, because it does, I found it, to have a much steeper learning curve than femoral access. And I've done quite a few radial access cases, and I'm always amazed by, for me personally, how less control I feel like I have over the catheter than when I am just doing a femoral access type of case. And also keep in mind, there's more potential for radial artery spasm, right? I mean, especially if you're going to hit the radial artery a couple of times and you're trying to thread a wire through it, a lot of times you will get some spasm, especially if, for the less experienced operators, that can certainly happen. As far as femoral access, though, a higher risk of retroperitoneal bleeding, obviously, and some pseudoaneurysm formation risks. But the operator does have a more direct route to the target area. We typically have the potential for a larger system, right? I mean, we can absolutely use 8 French systems, which we use very often in neurointerventional cases. And we obviously have a much larger body of experience because when the field came about, femoral access seemed to be the standard go-to, although it seems to be shifting quite a bit. So as far as it goes for myself, I typically espouse considering the patient's anatomy, the complexity of the procedure. When for a practice that is just starting to come about, or for an operator that is just coming out of fellowship, I think it's okay to start with radial access, but I typically suggest starting with some femoral access just to get a little bit more comfortable, and start with a 4 French or a 5 French system, and then work your way up to doing more radial access cases, right? Once you get to those higher volumes and you're trying to do diagnostic angiograms on outpatients, then I think it's perfectly fine to start doing radial access. In fact, it's probably preferable at that point, right? Patients like it a little bit more, and you're able to get those patients in and out in slightly faster fashion. So one of my passions when I started doing neurointervention was the quality of diagnostic angiography. I looked at so many diagnostic angiograms and CTAs and MRAs, and we all have, right? And one of the things that my mentors really drilled into me, and it's something that I tried to carry over, is when you look at a diagnostic angiogram, you look at it and you say, is this a good image, right? Does this image make sense? Is it pleasing to look at, right? Is it a nice, beautiful image? That might be a more radiologic point of view, but I think that it makes a lot of sense when you're looking at these diagnostic angiograms. And in order to know what's wrong with an image, I think that, or what's right with the image, I should say, you have to really know what's wrong with it first, right? So when I look at a diagnostic angiogram, and I threw this one in there, these are all images that I took, right? And this patient was, there was a language barrier. He only spoke Chinese, so I was doing it through an interpreter service in the room, and the patient, he was encephalopathic, and so there was quite a bit of, the patient's just not staying still. Well, that gives us a imperfect image for a diagnostic angiogram, right? And you see it here, right? The image suffers from a lot of motion degradation. The image is underpenetrated as far as the contrast goes. And what I like to see, what I like to look at, is if you look around the bone, there's a lot of dead space, right? So I didn't maximize the image as much as I could. I tried to, right? But obviously I was trying to hit a moving target, and so I couldn't. When you compare it to what I consider to be a more beautiful image to look at, right? You look at this diagnostic angiogram, and so we're looking at a lateral view, and this patient, I used apnea to get the image, so I asked the anesthesiologist to hold the breath. The contrast penetration was appropriate, and I found very little dead space around the borders. Now, as far as the contrast penetration goes, what I like to look at is, if I'm looking at 2 vessels on the diagnostic angiogram, am I able to see which vessel is in front of what vessel? I don't know if you guys, when you guys trained, if you guys did stereo images. If you did, I would love to hear about the experience, because my mentor made me sit in front of multiple computer screens, and he would make me hold a pencil in front of my face, about equidistant from my face to the screen. And I had to do that and cross my eyes until I saw the image that I was looking at in 3D. And I knew that the image was a high quality image if I was able to tell which vessel was in front of what vessel when I was doing that, as opposed to when I just moved my finger or the pencil away, right? I haven't run across a lot of people who were trained that way. I don't know if it's popular. I thought it was just kind of a neat tidbit, but it did help me to gain an appreciation of, when you're looking at these diagnostic angiograms, is the contrast so penetrated? Like, are you just seeing all the vessels in complete black? And so you really can't tell. You almost can't see or appreciate that it's a three-dimensional image, right? When I did this, I remember doing this diagnostic angiogram here, and I thought to myself, "Whoa, this is a nice diagnostic angiogram. This is a nice image, right? You can barely tell that there's any bone." And so I was proud of myself. And then I remember that my attending pointed out, he's like, "Well, what about all the dead space that you have above, right, where the vessels are, right? Like, look at all of that dead space." And that really did drive home a certain point for me. And that is that if you're going to take the risk of doing a diagnostic angiogram, you really need to ensure that none of the images that you take are throwaway pictures, right? Because you're in there, you've catheterized the vessel. These images are not just, they're a record of the patient. They're going to be sent, right, to PACS, and your name is forever associated with those images. So you want those images to be as clear and as informative as possible. And so when I looked at this image, all of a sudden, an image that I thought that was actually very nicely taken, I realized that there was still quite a bit of a ways that I had before I could actually generate what would be considered a really good image, right? And so I know what a lot of people are probably thinking is, why does any of this matter, right? Like, okay, whatever. I mean, you see that there's clearly a basilar tip aneurysm. That's what you need to know. You can probably get good images from, you can get a good three-dimensional image from this. You can get all the measurements you need. And that's true to a certain point, right? But wouldn't it have been nice for me to be able to see the vertebral arteries below it, because I probably could have seen quite a bit, right? I probably could have seen at least like C1 and C2 in this image if I had just moved the II down a little bit. So, like I said, it matters because of risk, right? No diagnostic angiogram is without risk. I've always quoted that in the best of hands, the risk of just doing a simple diagnostic angiogram is anywhere from 0.5 to 1% complication rate, right? So 1 in 100 to 1 in 200 of anything going wrong. And I tell patients that. You can get we can injure the vessel in the leg. There's a minor risk of infection. There's a minor risk of dissection that could cause stroke, right? We've all seen it. We've all been there, and we know what the risks are. But good angiography allows for the best working projections, which is why I think that starting out with excellent diagnostic angiography is probably the most important thing that we can do. So we look at this, just, run-of-the-mill basilar tip aneurysm. We can take a tour around it. And that's what I like to do. I like to generate a three-dimensional image. And, yes, I did use this to generate, to get some measurements, which, by the way, measurements should always be taken from the DSA and not from the 3D. But, you can still take some measurements from the 3D and use those to corroborate what you're finding on the DSA. I think that that's okay. But any decision-making regarding sizing a coil or a stent should really come from the measurements taken off the DSA. There's a lot of things that can be done manipulatively from the standpoint of the three-dimensional image. You can actually, as you guys know, you can play with the shading a little bit, and that'll actually change the measurements that you're getting off the caliber of the vessel. So if we take a tour around this aneurysm, right? So what I did was generated what I thought was a nice DSA, generated a nice 3D image. And then what I like to do is, and it takes time, it's painstaking, right? But take a tour around it, right? And that helps me to get a better understanding of the angioarchitecture of the aneurysm, right? To me, this is how it starts, because now I know what's coming off of the aneurysm, what's coming from the neck. I have a better idea in my mind of what might pass, what might fly, what might not fly. As far as three-dimensional spins go, right? I think that you should always use the feature when it's available to you when you're treating an aneurysm. It allows you to better understand the angioarchitecture of the aneurysm, and it allows you to find the best working projections. So that allowed me to essentially go ahead and say, okay, now that I've got the angles that I want, I wanted to get something where I can see the neck clearly and I can see all of the vessels, the P1s, the SCAs, the duplicated SCA in this case, right, coming off the vessel. And then I just started coiling, right? And as you just keep going, what I did was I tried to fade it out with DSA so that you could get a better idea of what it is that we were accomplishing here, right? Essentially completely coiling off this basilar aneurysm while maintaining no parent vessel compromise. Right? And seen from the lateral view. Now, here we go. One of the last images that I took for the case. And okay, I mean, I'll give it to myself. Slightly better image, right? There's a little bit less dead space. There's no motion degradation, so that's good. Less dead space, but still, I probably still could have done a little bit of a better job, but it was better than the first image that I took, right? So I thought that that was pretty good. And then there it is in the lateral. And you can see that you've definitely obliterated the aneurysm in a very nice fashion. It's no longer filling. The patient would definitely need some follow-up angiograms to see if they're, you know, if this is continuing to fill or not, which is something that we can talk about afterwards. Now, you remember when we first started in the first couple of slides, the first angiogram that I showed that I said was a good quality angiogram was the actual exact image here. And you're looking at it, and I was looking at this in the lab, and I'm purposely not showing the AP view because I love this image for the fact that it illustrates that you really have to look and perform very careful angiography. So if anyone noticed anything, please speak up. But what there was hiding in plain sight was an aneurysm. And so it's right there. It was a right MCA bifurcation aneurysm. And when you look at it from the other image, it's right there, right where the red arrow is. And almost impossible to see on the lateral view. So it really goes to say, always performing careful angiography is the cornerstone of what we do, right? And what I did was I used that to generate a three-dimensional image. I took some measurements, and then in the last image there, you see I treated it with a web. And the reason that I chose to treat this was because this was a patient who had a intraventricular hemorrhage approximately 1 year ago. A source had never been found. Now, I don't think that the intraventricular hemorrhage had anything to do with this aneurysm. I don't think that it ever ruptured, but what it told me was this patient has a propensity to bleed in his brain, right? Don't know why, we don't really know at the time, and may have been just a hypertensive bleed, right? But at the same time, he was young, he was in his early 50s, and you see this aneurysm and you say to yourself, okay, he's got many years to live. And so when I see a situation like this, I think that probably a lot of us would agree, best thing to do is let's just treat this, let's just take care of this so that it doesn't become a concern later on in his life, especially because he's got a propensity to bleed in his head. So, must be wondering, right? A lot of times, one of the first things that comes up when you discuss where you work is, oh, how many strokes did you do last year, right? It seems to just be a question that everyone asks. And the reason is because it's becoming big. It has become big. There's no way around that, right? The other thing is that obviously, and I say obviously, but I remember being in a meeting once with anesthesiologists, and the anesthesiologist, clear as day, looks at me and he says, we have a high volume of cases that we need to do. Is there any way that you can schedule these? And I thought that was very funny. The bottom line, though, is that while it's always a service, right, that a neurointerventional practice offers, it does throw a wrench in your day. We've all experienced it, right? You've got 3 or 4 cases lined up, and then you get a stroke, and you have to go through the decision-making algorithm of, are you going to do the case or not? And then you're going to take that, and it's really going to affect the rest of the workflow for the day. And it's just something to keep in mind, right? Now, really quickly, just getting into, I know that, we said that we were going to talk about diagnostic angiography, but the reason I'm throwing a lot of this stuff in here is because, to me, understanding the diagnostic angiography behind the procedures really helps to understand what it is that we're doing here. One of the things that when I was a fellow, the biggest aha moment that I had was when we were doing strokes, and we would see these patients who would come in and they had a clear as day M1 occlusion, but the stroke scale it was there. It was something like a 5 or a 6. And I'm thinking to myself, how is this? What's going on here? Because you're missing an enormous vessel, an enormous conduit of blood to that hemisphere of the brain, but you're not showing as many symptoms as I would expect for you to show. And when I understood the concept of the PL collateralization coming from the anterior cerebral arteries, that's when I had this moment where I'm like, all of it made sense to me in that moment. It's all about physics, right? It's all about the path of least resistance. The M1 tends to be larger than the A1, and the effects of gravity are also probably at play here, in the sense that in order to get blood into the anterior cerebral artery, you've got to go upwards. But to go through the middle cerebral artery, you don't have to go as much upwards. You're sort of going sideways, right? That's put into very simplistic view. But when you have an M1 occlusion, now the path of least resistance has automatically by default become through the anterior cerebral artery. One of the things that I like to ask medical students and residents is, so when you're looking at these PL collaterals, what do you think is actually going on? And invariably, a medical student will say, well, the brain's incredible. It's actually, it's creating these vessels that are going to dive down and save the cortex. That's not really what's happening, right? Those vessels are there. The more simplistic answer to what's going on is that the physics has now taken over, and what you're actually seeing is a different conduit, a different route for the blood. It sort of ties right into the biggest difference between what a CTA is, what an MRA is, and what a diagnostic angiogram is, right? What I always ask people when I'm talking to medical students or residents, and I say, well, why do we have a job, right? And invariably, someone's going to say, well, you can do strokes, you can do aneurysms. And I said, no, but what I'm asking you is, what is the fundamental difference between a diagnostic angiogram and a CTA, right? Because CTAs are incredible nowadays. They have high resolution, they give you beautiful images, especially if the patient's laying still. So why do I have a job? And, what I'm getting at is that it's not how we're not interested in seeing whether something is filling or not, right? We're not interested in seeing if the blood is there or not. You can see it clear as day on a CTA, but the real question is, how did the blood get there, right? What path did it take? You look at something like this where a patient's having a stroke, and now you're thinking to yourself, okay, so the collaterals are now kicking in, so there's clearly a problem. Yes, there is a problem. There's an M1 occlusion, right? And so this is how some of these patients can come in and have a lower stroke scale than you would expect, right? Their collaterals have kicked in. Now, again, going through the path of least resistance, right? In the pre-mechanical thrombectomy, the path of least resistance is going through the ACA. Once you've removed that blockage, now the path of least resistance is clearly through the MCA. So now we've reestablished the normal blood flow path. And you'll notice, though, that you'll see a lot less collaterals in the post-mechanical thrombectomy because you don't need those collaterals. However, that doesn't mean that they're not there. Those vessels are filling. They're simply filling in a different direction. I threw this in there, the system may fail after prolonged periods of maintaining a high cerebral perfusion pressure, or as we all know, sometimes patients get into the emergency room and then, someone with less experience will say, oh my God, this patient's blood pressure is 210 over 120. Well, we cannot have this patient, living in these, living at this high pressure. I can't tell you how many calls I've had from transfer centers where the ER doctor is like, yep, don't worry about it. I took care of it. I brought down the blood pressure to 140. Patient's normotensive now. Patient's also getting worse, which is why I'm calling you. Well, there's a very clear reason for that, right? This is all just physics. One of the really interesting things that I've always found is, even in the best of hands, and even when the patients get to you as quickly as possible, those patients still with, patients with M1 occlusion still end up having a basal ganglia stroke, right? And once you start to do these enough, you start to understand why. The lenticular striates coming off of the M1, these very thin hair-like particles that we've all sort of noticed on these diagnostic angiograms, right? They're all coming off of the M1, they're feeding the basal ganglia. So depending on where the clot is, and typically, it's proximal enough, these clots are proximal enough that they cut off the lenticular striates. Now, even the most robust collateralization system is not going to be able to dive down deep enough to get to the basal, to feed the basal ganglia. So even in the best of hands, most of these patients end up having a basal ganglia stroke, right? A lot of times I've had calls from the ICU, and I personally thought, wow, we saved this patient's life, right? We did this mechanical thrombectomy. We saved all the cortex. And then the ICU doctor will call and say, yeah, the patient still had a basal ganglia stroke. Okay, well, that was likely unavoidable in this case. The real question is, did we salvage the penumbra? Did we salvage the remainder of the cortex? And the answer is a lot of times we have, right? That's why we do these procedures. And so in this particular case over here, as you can see, right, you've got an entire M1 that's out. Patient got there on time. We pull out the clot. Patient ends up with what would be considered by most to be a small stroke, right? I mean, it's just a small basal ganglia stroke. Patient's going to do just fine. The remainder of the cortex was salvaged by the ACA collaterals, right? But invariably, that is why terminal ICA occlusions are always so much worse, right? Because when you take away the potential for having that ACA collateralization system, well, now you've got failure of both the MCA and the ACA. And so now you cannot rely on your ACA collateralization system. These patients tend to have much less time, as you've probably all seen, than the patients who have just a straightforward M1 occlusion. These patients I found very, very important to get them into the lab as quickly as possible. Now, that's the case for all of these types of strokes, but especially with terminal ICA occlusions, I sort of go in there talking to the family and saying, listen, like, this is a really bad one, right? We're going to do everything that we can, but I just want you to temper expectations because there's nothing that is salvaging this patient except for the amount of time it's going to take us to get the clot out, plus however long the patient has been ongoing with these symptoms. Just very quickly looking at how some of the mechanisms that are in play. You've got a thrombus. We like to talk about penumbra and core, right? So what's salvageable versus what is not salvageable. We've got a lot of fancy technology nowadays that can help us make these decisions, right? CT perfusion scanning allows us to look at the core versus the penumbra, the salvageable amounts of tissue, and we can use that to make a decision regarding the utility versus the risk of a mechanical thrombectomy, right? I mean, now, that is to say, though, I don't 100% rely on this, but I do use it to bolster my argument as to whether to take a patient to lab or not. And that's really where I think the most important aspects of utilizing these images are. Don't get the image if you're not going to use it to make a decision about what you're doing, or if it's not going to add a data point to your line of thought, right? A lot of times we get these CT perfusions and they show exactly what the CAT scan already confirmed. There's a very large core, right? So you're not necessarily going to use the perfusion scan to say, well, I think we should go ahead and do it, right? Unless the perfusion scan shows you something that really gives you pause and makes you say, well, you know what, there's much more salvageable penumbra than I actually thought. So maybe it is worth a try, right? And we've all sort of had experience now with Rapid AI and Viz AI, where basically what they're taking is a proprietary algorithm where they essentially look at the CT perfusion scan and say, we can, the algorithm thinks it's a good idea to go ahead and do the case, or not so much of a good idea, right? So over here, if there was a core, you would see it in purple on the image on the left, and the penumbra, the salvageable tissue, is the image on the right. So you divide one by the other. Here, the mismatch ratio is infinite. So the patient, in theory, does not have a core yet. And so this patient would be considered a good patient, right, to take the lab. Now, there's a lot of data coming out now. There are a lot of papers coming out talking about like very large cores, aspect ratios that are pretty low, still taking the patient for salvage procedures. And I think that there's very good data behind those. A little bit beyond the scope of what we're talking about today, but I think that there's definitely, those are still a worthwhile endeavor. You just have to be able to temper expectations with the patients. Really just going through the technique very quickly. Now, I will say I liked these images, but obviously nowadays we've sort of changed a little bit about how we do strokes, or not always, but a little bit, right? We're going to always take a guide catheter. We're going to take an intermediate catheter. We're going to have a guide wire. We usually have a micro catheter with it as well. We can typically pass the clot, although what I've been trying to do nowadays is not pass through the clot with my wire. I actually just try to get it to the interface of where the clot is. And then, you bring up your micro catheter, and then you're going to take you're going to take the wire out. You're going to put a stent retriever in. Now, that stent retriever, what you're going to do with it is you're going to slowly unsheath it. And the idea being that you're going to cork, right? You essentially cork your stent retriever and your intermediate catheter together so that you have essentially created a cork. And then you're going to pull the whole thing out, right? And you're going to get the clot out and reestablish normal blood flow. And that's a perfectly fine way of going about it. Nowadays, what I like to do a little bit more is to just try aspiration only, especially if these patients have had TNK or TPA. And I find that to be a little bit less traumatic on the vessels, less incidence of bleeding. And one of the important things, though, is that what I have found is some of these new catheters that are out on the market, they are navigating through the ophthalmic segments, which has always been an issue. They're navigating it incredibly well. And so it's becoming less and less useful to need stent retrievers. I think that that's the natural way that the cases that we're doing are going, but interested to hear what you guys, your experience with it. Just some images, right, of illustrating how this actually works. One of the things that I like to talk about, though, overall, is the transformative power of what it is that we do and the potential for what it is that we're doing in this field, right? Had a 40-year-old man, multiple years of pulsatile tinnitus in the left ear. He came to medical attention at the request of his fiance. They had just gotten married. She thought it was very odd because he kept complaining about it, right? And did a diagnostic angiogram, and what we see, enormous, just an absolutely enormous aneurysm. Obviously, this is going to cause some pulsatile tinnitus. One of the things that I find to be interesting about these is, well, for starters, there's going to be a lot of clot in these aneurysms, okay? So in the argument of what do you do with this? How do you treat it? One of the first things that I tell patients is, look, there may be a ton of clot sitting in this, and those clots may start flicking off and going up into your head and causing strokes. And so I think that the first thing that we need to discuss is we probably need to have this treated. Now, there is obviously quite a bit of risk involved, and we talk about that. And then, then it becomes decision-making time, right? How are you going to go about this? So what I did for this case was I treated it with a pipeline embolization because I thought that the best way to get about it was flow diversion and to try and get a much more normal configuration of the vessel. Again, I generated a three-dimensional image from it, And what's interesting, though, is that if you look at the diagnostic angiogram, right, one of the first things that you're going to notice is you're not really penetrating much contrast into the intracranial vasculature. And that's because a lot of it is caught up in the aneurysm. And so you're not really, you're really under penetrating by quite a large margin here. So in order to get the three-dimensional image, I really had to push very hard, which is sort of a little bit of a harrowing experience, because you see that you've got this enormous aneurysm here, and you're going to use a pressure injector. Obviously the first thing that I thought of is, what if I rupture this? Oh my God. But we went ahead and did it, not too high of a pressure, but enough. We also used, I used quite a bit of a delay to allow the contrast to penetrate through the aneurysm, circulate through, and get into the intracranial vasculature. Here are just some of the measurements for you. So pretty big. And then what we did was, and this was the final image 6 months later. So what we did was we went in and essentially, and for reference, that's the area where the aneurysm was, right? And all I did there was essentially create a pipeline construct, right? And just essentially put a couple of pipes together, one in the other. I double covered over what I felt to be essentially the neck of the aneurysm to really reconstruct the vessel from the inside out. I love this image because I think that, in my opinion, this shows you the power, the transformative power of what we do, right? These patients probably didn't have much of a chance before what we do came about. Or it would require an open procedure that was highly morbid and with quite a bit of a risk involved. Not to say that there's no risk in treating this with pipeline embolization devices, right? You will certainly get more contrast stasis. The contrast stasis could, in theory, lead to rupturing the aneurysm in and of itself, strokes, right? So it's not without risk, but done carefully, with the correct amount of dual antiplatelets. And if you have a game plan in mind and you go in there and you execute the game plan while you were completely of sound mind, I do feel like there is definitely a path forward to treating these, and that's how we did this. So I think that's all I have, and I was leaving some time here for questions, which I am happy to do my best to answer for you.
Great. Thank you very much, Dr. Dancour. Chizama, over to you then.
Thank you, Dr. Dancour. That's a wonderful presentation. Thank you, Dr. Bankole. Before I go to Dr. Dancour, Dr. Bankole has been very persistent and very, very insistent on continuing this grand rounds. And we are really excited about the future as we continue to work together with all the stakeholders to facilitate world-class comprehensive neurointerventional services and stroke center in Nigeria, as well as in other West African countries. We have more information that will be forthcoming in the future sessions about opportunities for anyone interested in engaging in this much needed work. I don't see any questions coming up. I don't know if anyone is holding on to a question. Please, let me look. I don't see any hand raised. Usually when you don't have questions, it's because you've given too much information.
Yeah,
you've given too much, and people may have something they want to ask, but before the talk ends, the question gets answered. Uchenna, Dr. Okafo, I see your hand raised. Please proceed.
Good morning once again. I want to thank Dr. Dancour for giving us such a wonderful presentation. I saw this enormous aneurysm. I'm like, oh my God, have mercy. What a fantastic job. Okay, so I just want to keep it as simplistic as possible. We're starting the services in conjunction with Prof. Bankole and the team in Nigeria. And diagnostic cerebral angiogram is something that may be a little new for providers, neurosurgeons, neurology colleagues, and all the allied specialties, of course, ENT, ophthalmology. Can you just give us an idea of what kind of cases should people be referring for diagnostic angiogram? Of course, there's CT available in Nigeria. We do CTAs, they have MRIs, but diagnostic angiogram is something new for the provider. So they're kind of wondering, is it, oh, patients wasting money? Or what kind of things should be referred? You talked about tinnitus. So somebody who felt tinnitus is benign can, end up with this massive aneurysm that you just showed us.
Right.
So what kind of things should people see or come across in their practice and should refer day-to-day things from allied specialties, just to give everybody here an idea of
Right.
how powerful diagnostic angiograms can help us?
Yeah, no, I think it's a great question, because I think, all too often, especially in the United States, right, sometimes we use diagnostic angiograms almost as exclusionary in a way, right? I mean, and I think that comes as a result of just having the luxury of being able to do a diagnostic angiogram, no problem, right? So I've had many neurologists call me and say, I have no idea what's going on with this patient. Can you do a diagnostic angiogram? And I say, oh, okay, yeah, no, sure, no problem. Let's do a diagnostic. And, and then sometimes what ends up happening is I tell the patient, listen, I don't know that I'm going to find anything, but that might actually be a good thing, right? And then it tells us that it's not like a giant aneurysm or an AVM or a CC fistula or something that could be doing this. So I think in order to answer that question fairly, it really requires having a very, very open mind. Obviously, things like unexplainable pulsatile tinnitus, I want to say things like, stroke in young people that were never explained, traumas like motor vehicle accidents or any kind of trauma to the neck that may have caused a dissection that you can't quite really see on the CTA as well as you'd like to. I mean, I can't tell you how much of like how many times I've seen carotid dissections that have led to unexplained strokes because of stenotic lesions that were created or pseudoaneurysms, right? And so you take those and then you treat them, and all of a sudden, like, guess what? The patient gets better, right? They don't have any more strokes. So I think traumas is definitely a big one. Pulsatile tinnitus, stroke in the young that was never explained. Gosh, let's see what else. I mean, a history of intracranial tumors, radiation, really, I think big things like that, as opposed to just saying, hey, I have no idea what's going on with this patient. I think that, eventually we can all get there, like in the sense of like, West Africa will get there at a certain point. But I think focusing on more targeted approaches as to why you're getting the diagnostic angiogram is probably the most fair way to go.
Yeah, thank you. I have two questions on the board. The first one is from someone, Kingsley, asking what the learning curve for this skill is like.
Yeah. I mean, I think that probably 50% of it is the manual movement, and maybe the other 50% would be whether to do it or not. So I think that the learning curve, in my opinion, is steepest for the part of it that's not mechanical in nature, and looking at it from the perspective of, should you be doing this or not, right? And which goes back to the first question, right? What's the indication for a diagnostic angiogram? Well, that's where I think the art comes in. That's where I think one of the areas where, an AI chatbot will not be able to really tell you whether you should get a diagnostic angiogram on a patient or not, because there is a certain level of human thought that has to go behind it. As far as the manual movements to do it, I mean, it really depends on what you're trying to accomplish, right? I think that most physicians who have competent skill level and some experience with radiology or neurosurgery, would be able to do a diagnostic angiogram. And I think as you progress into the finer minutia of, like, for example, treating an AVM or CC fistula or doing a giant aneurysm with pipeline embolizations, I think that's a little bit more tricky, right? Or doing a web device on a very flat but wide aneurysm, right, without like the risk of puncturing it. Yeah, that requires a certain amount of skill level. So I think a couple of years of learning how to do it, just like any manual skill, is definitely warranted.
Yeah, that's true. During training, Kingsley, as you would find out, you start by, first of all, learning what the indications are for cerebral angiogram, whether the patient in question meets the criteria to pursue the angiogram. What's the clinical status of the patient? Should you be exposed? Because like Dr. Dancour said, there's always a risk. We do cerebral angiograms every day and we get away with it, but there's always that one case, that will never leave your mind. So you want to make sure that you're actually doing this because it's really needed, not just because you want to test your skills or because you feel you have all the competence in the world that you can do it in your sleep. They say the enemy of good is perfection, right? Again, during training, first thing is how to handle the catheters and why, identifying which catheter you need for which case, what's your route? Are you going femoral? Like he said, and I agree with, you want to start off with knowing how to get femoral access. When in training, and I think Dancour as well, we kind of trained at the same time. You find out some older neurointerventionalists are very good with manual palpation of the vessel. They do the puncture without ultrasound. But I learned to do ultrasound, and I think in this age and time, it's best to always try to use ultrasound if you can, especially if you're new to the practice, because you don't want to puncture multiple times on the vessel. Every time you go and you come out, you leave a hole, and that's a recipe for disaster. And try to puncture always below the inguinal ligament. Sometimes it's challenging to do so with people with very big body habitus. But I rather puncture the SFA, the superficial femoral artery, than the CFA, which is the bigger caliber. But sometimes when you do that, you expose yourself to risk of retroperitoneal hematoma, which in training I have seen that actually led to somebody dying. So those are things, for people, the beginners, you have to learn what are the possible complications, how to avoid them, what to look out for when you do have complications, what to do. You have to have all this at the back of your hand before you start. That way, you do it more effectively. There's another question here from one of our listeners, Edward. He was asking about, he said he often read that diagnostic angiograms are best done with the intention to treat. And what our thoughts on these are? Well, again, before I hand over to Dancour, it depends on what the ask is. Every time you do a procedure, you have a question in your mind that you plan to answer. For example, the guy that came with tinnitus, you saw that huge thing. Could be an aneurysm, could be something else. You go in for diagnostic angiogram. You don't expect that you're going to treat that aneurysm right there and then. For diagnostic, most people, I think 99% of the time, we do diagnostic angiogram under conscious sedation. But every aneurysm has to be treated under GA. So you have to make plans with your anesthesiologist beforehand that you are going to treat this, that you're going to have a general anesthesia present. So for that case, for example, it will require that you first investigate it by doing the diagnostic first. Do a 3D run if you want. get to know the anatomy or the morphology, explain it to the patient, get their consent for treatment. Before you bring them back, this time you are better prepared, you are ready. And again, maybe the patient is not on antiplatelet. You want to put them on dual antiplatelet first. Sometimes you may even need to do a PRU, make sure that they are platelet responders before you put the equipment in their brain. So yes, even though your intention is to treat, but the first time you are seeing the patient may just be for diagnostic purposes. I'll leave it to Dr. Dancour to, I don't know if you have an input on that.
No, Dr. Zeppo, I completely agree with you. 100%, I completely agree with your sentiment. And I'm not sure if the question was getting at more intention to treat on the spot or intention to treat at a later time. I think that regardless, the conversation that I have with patients is that the diagnostic angiogram is going to give me a blueprint of what it is that I'm looking at so that I can have a better understanding of your anatomy, right? We can use that as a data point to make further decisions, right? So for example, if I see like a 3 millimeter aneurysm and it's got round, smooth, contoured edges, looks okay, and the patient's, I don't know, 80 or something, right? That changes the narrative of the conversation, as opposed to if I see, for example, a 3 millimeter aneurysm, but it has like a 1 millimeter daughter sac coming off of it that I didn't appreciate on the CTA. That sort of changes, now I have more of a data point to come to the patient and say, look, this aneurysm looks a little bit more concerning to me, right? I think that there's more of an argument here to treat. And I like to use the diagnostic angiogram in order to make decisions with the patients, not necessarily for the patients. I think that that's an important distinction.
Yeah, there's a question here asking about given the resource constrained setting, like in Nigeria, that it will be a little bit tricky given the cost and of course the risk, especially given that CT angiogram is widely available and sometimes adequate for pre-op planning. What is our thought? I think the question is asking, in limited resource locations, what do you consider as absolute indication for cerebral angiogram? I mean, I come from Nigeria myself, and I understand the limitations over there. In situations where it's possible, there are some cases where diagnostic angiogram is going to help in the long run. In some cases, even reduce the cost of treatment, in the sense that, for example, I've seen patients that have a CTA, they have MRI, they have every test you can think of looking for a problem, and you don't find it. But just a single diagnostic angiogram reveals maybe a severe critical stenosis of M1, for example, which may not be apparent on CTA. And you fix it or know that that's the problem. You have ended up preventing them from getting more testing done. So it's relative, really. And, I don't know if Dancour will be able to answer this, given that I don't know if you have practiced in a limited resource location yourself.
Right. No, I haven't. But I very much appreciate what you're saying. And I hope to, by the way, I do hope to work with you guys. I think that, I completely echo your sentiment. I think that there are many situations in which I would say, you know what, there is something that I think is headed towards treatment. And if I feel comfortable enough, right, I would say, I think that we can do all of this in one shot, do the diagnostic angiography with the intention to treat on the spot and save yourself having to do a diagnostic angiogram plus something else, right? Obviously, the question of do we treat this to begin with is a completely separate conversation. But as far as the resource limitations go, I think that this can be done in such a way where we take all of that into account and say, I think we're all reasonably confident enough to do the diagnostic angiography and perform the treatment on the same day at the same time, It's going to require a little bit of, more anesthesia time, but it's also going to require a little bit of sitting back, looking at the images, goes back to careful diagnostic angiography and then treating on the spot. But I think that there's a role for that.
Yeah. I do have a question myself. More and more with regards to radial access for thrombectomy, I tried it in the last 2 years or so, and I just went back to doing femoral. In my own experience, I found that, when you need more than 0.07, more than 0.71 size catheters, it's really hard to find something that you can go radially. I have, recently been using BMX 81, and the most you can go through there is 068. It's, if you have a very large M1, sometimes again I adapt the aspiration first technique, and I try as much as possible to avoid stent retrievers. In fact, we're beginning to take them off our shelves. Because if you can aspirate and get the clot out, why would I risk putting a stent retriever that will cause shear in the intima and may increase risk of bleeding? So do you do more radial access for strokes? I use radial access for anything else, everything else, but for stroke, I just go femoral.
I also go femoral for strokes.
Mm-hmm.
I think that for a couple of reasons. First, I have much more control with femoral access for a stroke. The idea behind the stroke is, you're not really as concerned with the patient comfort. Most of the time, like for me, I do strokes under general anesthesia, so they're intubated, so they're not going to feel it. I'm comfortable with the risk associated with getting femoral access. I have found that, if I'm going towards the left, if I'm going to the left side for the stroke, I have much more control with the catheters. And so really, strokes are that one thing that we do where you don't get any points for the stylistic way in which you do it. You just have to get the clot out, right? And so for me, my comfort level is get femoral access, get the clot out.
And also, the other question I have is, and people talk about this all the time. We, in these modern times, the contrast we use for neuroangiography, more and more less nephrotoxic as possible. The IsoView 370, for example, is the one I use in my lab. People worry about renal complications, especially for people with people who already have CKD or people on AKI. Do you have a threshold for renal function when it comes to angiography?
That's a great question. We always see these. So as an aside to that, I'm amazed by how many times I get called by a team or by an ER doctor saying we didn't do a CTA because of the nephrotoxic effects, but do you want to do a diagnostic angiogram? Well, thank you for passing the buck to me. No, do I have a threshold? I mean, I always answer this one carefully. I don't necessarily have a threshold. And the reason is because if it needs to be done, then you can always dialyze it out, right? If the diagnostic angiogram needs to be done, then yes, let's dialyze it out. If it doesn't need to be done and you're just doing it as a luxury, then yeah, it's a conversation to have with the patient. Do I have a specific number in mind? No, I mean, not particular GFR. I mean, I would say not necessarily, because right, you're not going to withhold treatment from a patient having a stroke because they have a GFR that's not ideal. But at the same time, I mean, if it was for the elective treatment of an aneurysm, then maybe, for example, it might be a worthwhile endeavor to consider doing the diagnostic and the treatment at the same time, just to save on the amount of contrast, right? And it's sort of the same thing with, we've all done strokes on women who are pregnant or young women, right? And what I like to do there is I try to get my frame rates down so that I'm using less radiation overall. I think that that's always a consideration, right? So I think anything that we can do to make the procedure safer for the patient as far as, the long-term side effects, I'm all for that as well.
Yeah, yeah, I think I share your sentiments. I was asked the same question, and I answered exactly the same way you did. So I'm glad that I didn't give a wrong answer. You know, yeah, yeah.
There's quite a
So
bit of art to doing this, is what I found over the years, right? So
yes, yes. All right. I don't see any more questions here, and so I'm going to turn it over back to Professor Bankole. Once again, thank you, Dr. Dancour, and it's been very insightful.
Thank you very much. Thank you for having me, guys.
Right. Thank you very much, Dr. Dancour. If I may just contribute a little bit and say that, so here, like has been mentioned, we sort of have a lot of DSA, CT angios that we do. And I'm just thinking that, would you think that for us, maybe because again, cost is also an issue that, should we like reserve the DSAs for, or use the CTAs more like a screening kind of thing, and then reserve the DSAs for maybe if you have a CT negative kind of CTA negative or MRA negative study in a patient that's had maybe a subarachnoid or something like that. Would that be a reasonable middle ground, at least to start off with, or something?
If you're asking me, I absolutely agree with that. I think that, if you have a CTA negative or an MRA negative subarachnoid hemorrhage, and it's clearly not due to trauma, I think that patient deserves one, at the very least, one diagnostic angiogram, right? I think if I remember the data correctly, you definitely get diminishing returns the more diagnostic angiograms you do in a case where you have an unsourced hemorrhage, right? But if I remember correctly, you'll find a source in approximately 2/3 or 66% of when you do the first diagnostic angiogram. It drops dramatically, right? I think to like 33%, and then maybe even like 12% after that by the time you do the third diagnostic angiogram. So resource utilization being kept in mind, I think that one diagnostic angiogram, in my opinion, is a worthwhile endeavor. I think that anything after that is probably quite a bit of a luxury in the sense of, finding it, and you can probably be on the correct side of the statistics if you do it carefully.
All right, great. Thank you very much. So before we conclude today's session, I would just like to inform the participants that our next ground round will take place on the 13th of August, 2025. You can refer to the shared flyer on the screen for details, and we look forward to seeing you there. And for those of us that are in Nigeria, we're going to be having a neurovascular camp toward the end of this month, and we're going to also have a workshop on pediatric pediatric angiography. That will be on the 30th of June. So those of you that are in Lagos can feel free to join us. If you have any idea of topics that you like presented in future grand rounds, please reach out to Dr. Okafor or myself. The recordings for today's as well as previous grand rounds are uploaded onto the West African Stroke Initiative YouTube channel, and the link of the channel is in the chat box. Thank you everyone for joining us, and we hope this session has been valuable for you. Thank you again, Dr. Dancour, for the excellent presentation. Thank you, Chizoba, for a great job moderating, and have a wonderful rest of the day.
Thanks, everybody.